It's my pleasure today to introduce our president to the American Head and Neck Society, Dr. Terry Day. I've had the great opportunity to know and work with Terry for about the last 15 years or so. I certainly consider him a great colleague and friend. Terry has a great tie from the Midwest, having grown up in Oklahoma, completed his undergraduate and medical degrees at the University of Oklahoma before going to Louisiana State University to do his residency training with Dr. Fred Stucker, who I believe is here this morning as well. To really pursue and solidify his career in head and neck surgery, he completed his head and neck fellowship at the University of California, Davis with Paul Donald, and managed to squeeze several months in there to also go to Bern, Switzerland to study craniofacial surgery. Upon completing his training, Terry joined the faculty at Vanderbilt University for a number of years before being recruited away, wisely I think, by Dr. Paul Lambert to the Medical University of South Carolina, where he remains today. He serves in multiple capacities there. He's the Wendy and Keith Wellen Endowed Chair of Head and Neck Surgery. He's the director of the Head and Neck Tumor Center at the Hollings Cancer Center, and he's the vice chairman for clinical affairs in the Department of Otolaryngology, Head and Neck Surgery. He's published over 100 peer-reviewed articles, has co-edited 4 textbooks, and has been a very active clinical researcher, has been involved in multiple grants, has served on the Head and Neck Subcommittee, the RTOG, as well as the NCI Head and Neck Cancer Steering Committee. Probably what's most remarkable, from my opinion, about Terry is his tremendous commitment to service, both to his institution, to this society, and certainly to others as well. And there are really too many to list, but respective to the American Head and Neck Society, Terry has served on the program committee for 5 of our meetings, has been a member of the CME Compliance Committee, the Publications Committee, Prevention Committee, which he chaired. Has also been a trustee for the Research and Education Foundation. He's also served as a site visitor for the Advanced Training Council for our fellowship programs, served on the council for 3 years, and obviously has served as vice president, president-elect, and now president. He's also been very active with IFNOS and with the American Academy of Otolaryngology, Head and Neck Surgery, and he's chaired multiple committees there, as well as served on the board of directors and the executive council. Let me tell you about a few of the things that Dr. Day's done beyond that. We heard at the opening ceremony from Pat Glane, gave us a very nice talk with the Hayes Martin lecture, and talked about elevating awareness and the importance that is in prevention. And Terry certainly had a long-standing commitment to these issues. As the founder of the Association for Head and Neck Cancer Awareness in 1997, an organization that combined efforts with the Yale Brenner Head and Neck Cancer Foundation to form the Head and Neck Cancer Alliance, an organization that does have a booth here, and I hope you'll stop by to talk with them. With that, with those organizations, he helped start the Head and Neck Cancer Awareness Week in 1998, and that has evolved into the Oral Head and Neck Cancer Awareness Week in 2001, which most of the institutions present in the United States, at least, have participated with, I'm sure. He's also now the International Director for Oral Head and Neck Cancer Awareness Week. And the Head and Neck Cancer Alliance really serves to elevate awareness, to provide cancer screenings during that week in particular, and to raise funds to support head and neck cancer research. Some of his other notable activities, I could go on all day, is one of the founding members of the International Academy of Oral Oncology, and has really served on multiple surgical trips to Haiti over the last several years. Not surprisingly, he's been the recipient of multiple awards at his own institution, the Medical University of South Carolina. He's been recognized as the Teacher of the Month, as the Outstanding Clinician Award, Faculty Excellence Award, and Humanism in Medicine Award. He's also been recognized as the American Academy of Otolaryngology, Head and Neck Surgery with the Jerry Goldstein Public Service Award, and by the Trilogical Society with the Presidential Citation. There's no question that Terry was an outstanding choice as our leader for the Head and Neck Society this past year, and he's done an incredible job. He's worked very tirelessly to advance the society and all our missions overall. Before I hand the podium over to him, however, I'd like to tell you a few other things about Terry. If you don't know him, he is an avid outdoorsman, loves the mountains, which is odd for a guy who lives in South Carolina, but manages to get up there wherever he can, whether it's fishing, boating, hiking, mountain biking, climbing 14,000-foot peaks, or making a solo ascent on Mount Quandary in the dead of winter on his skis. Highly questionable judgment, I would say, on that one. Or running a relay race with his friends from Mount Hood to the Oregon coast. He's been a great friend and colleague. It's been a pleasure to work with him. Had a chance to co-edit a textbook with him a number of years ago, something we swore we'd never do again. But I noticed you have done it again, so you didn't learn much there either. He's been at the meeting this time with his teenage children joined us at the meeting, and actually this was earlier this week. Lisa Schneider hosted us to a Russian extravaganza dinner over in Coney Island, and Terry's children, Austin and Meredith, were able to join us for that. And I think they're enjoying their first experience in New York City. I hope they didn't make it out on Times Square last night. I'm not sure what happened. But Terry, it's been a pleasure and honor working with you, and this year, and really the last many years. And ladies and gentlemen, I give you our president, Dr. Terry Day.
Thank you, Doug. Very kind words. Appreciate everybody being here. They said it's the city that never sleeps, but it looks like a lot of people are still asleep. I didn't look back when I was sitting down there. Now I see, okay, so the bagpipes will be in soon, and then the procession. So just you guys kind of clear out, make some room for them. Truly, it's an honor to serve this society for the last 14 months after taking over for Mark Wax, and it's just been an incredible run. We've had a lot to do, and we've accomplished a lot. So appreciate all of the support I've gotten. This is the wrong set of slides. Can I get the presidential speech slides? Thank you. We only went over that 5 times. This one. Thank you. So again, today we've talked about this several occasions. The Dr. Shaw, Dr. Yu, thanks for all of what you've done to get us here today, get us through the last year. Really, a lot of our efforts for the society have been behind this meeting and getting the details worked out. So I want to extend my appreciation to you guys. Also to the executive committee, Doug, Brian, Dennis, Ehab, Carol, and Dave. You guys have been there at my side. You guys have done a lot individually, and we've done a lot as a group, so appreciate that. The membership, thanks. It's really, I've been involved in this organization since the 90s, and it's truly the most active I have ever seen. Every year, people are getting more and more involved in the committee system, so thanks to the membership. And of course, thanks most of all to my family for their support during the past year. And I think we all know families are a priority, and always keep that in mind. And thank you. So we're celebrating a lot today. We're celebrating about 60 years since our parent societies, the Society of Head and Neck Surgeons, mostly a general surgery organization back in the 50s, the American Society for Head and Neck Surgery, mostly an otolaryngology society. And for the younger generation, these two societies merged officially in 1998 after years of discussion. And this was not an easy task, and that's a big reason we're here today. And so the past, what I'm going to talk about today, my initial title about a year ago was 15 years. Anniversary of the Head and Neck Society, and as I started writing it, I kind of felt my passion. My passion was patient care, and so I integrated that into this talk. And we're celebrating 100 years of surgery at Memorial Sloan Kettering, and the combined efforts here of IFNOS and the Head and Neck Society. We're also celebrating the rapid advancements in head and neck oncology that over the years have resulted in improvements in treatment as well as quality of life for our individual patients. This is a brotherhood of colleagues that have converged from around this planet, 90 nations, into one location, one hotel, to exchange ideas, research, education, and friendship. So this is a historic event. We're also celebrating our triumphs, our obstacles that we have to face in the future, and addressing those with new solutions. Most of all, our patients. So that's what we're celebrating today, and I'll be talking to you about our patients and our interaction, relationship, and bond that we need to have with our patients. As head and neck surgeons, we really have a unique opportunity to engage humans in life and death situations. And everybody in this room, preaching to the choir, you guys know it. We're facing life and death every day, every minute of every day, and we come home to our family, to our friends, and our outside activities, but in the back of our mind, we're thinking about that day and tomorrow. Somebody's facing death. Somebody's facing decisions on whether to continue a treatment for life or consider death. And so it's a unique group of physicians that we are, and we know that. We have opportunities for cure. We have a lot more opportunities for failure, not just in cure or non-cure of cancer, but in the quality of life. We have complications, we have risks that we're taking. And so the quality of life issues, and what's not talked about a lot, is patient self-image. And emerging research is showing that patients are caring about their image to themselves and to others around them, their family and friends. So what I want to stress is understanding a patient, family, their hobbies, their goals, and communicating the options to the patient while forming that physician-patient bond. So why this topic? Well, like many of you, I started keeping all the notes and letters and cards that the patients gave me over the years. So I have a file cabinet, and in my office keeps that together, and every single note or card or thank you. And so I pulled a few of those out, and one of them said, "Thanks, Doc, you saved my life." And I thought back, of course I remembered that patient. And did I believe I saved his life? No, I don't believe I did. Anybody in this room could have done the same thing. Thousands of other physicians and clinicians could have done the same thing. But why does this patient think that I saved his life? And it wasn't the surgery I did. It wasn't what I read about in medical school or in residency. It was that bond that we had undertaken to fight that cancer together. And that patient was there, and he wanted to partner with me to get through this ordeal, and we got through it. And so he considers that bond is what saved his life. And so, of course, they want to credit somebody, like a lot of times people blame somebody, and he wanted to credit his physician, his surgeon, you and me. And so that's where I went with this. I said, you know, this is such an important part of what we do, and we never think about it, and we never talk about it. So this is now published online, and I'm going to talk to you about the ultimate constant of head and neck oncology, the physician-patient relationship. And a lot of people have said that, you know, the only things that are certain in life are death and taxes. And so we've got to think, what else? Well, in New York, we know another constant, registration desk, outside, long lines, good pizza. And another constant in New York is they seem to hate the Red Sox for some reason. And that's in their blood. But I think there's another constant, and that's going to be the physician-patient relationship. And I don't think things can break that bond, although there are many efforts, and we're going to talk about some of those today. So when I reviewed the literature, I looked up how many articles, physician-patient relationship, physician-patient bond, patient-physician, head and neck cancer, head and neck oncology, and then I went to oncology. 0 articles on head and neck cancer and physician-patient relationship. About 3,700 articles on the physician-patient relationship, and I specifically looked at cancer, and cancer had a number of other cancers, obviously not oral, laryngeal, or head and neck cancer. So what I did look up was a few articles. Here's one that the study looked at patient-centered communication and decision-making intervention for physicians and patients with advanced cancer. And so they've developed a model where the physician and patient can communicate, they teach these values, and it improves patient well-being as well as healthcare outcomes. And that's their goal in this study. Deciding what information is necessary. Do patients with advanced cancer want to know all the details? And we all know they hear a fraction of what we've talked to them about. And so this addresses some of that, but this is a review article, so there is not a lot of research on this. So this is an issue because it's difficult to study, because it comes from our heart. There's not going to be a lot of publications on that. They found some of the physician factors and patient-specific factors that are involved in deciding whether or not the patient understands or hears what we're talking about. And so this will be the outline for today. We'll look at whether this is ancient history or current reality. Is change the only constant in head and neck oncology? The world we used to know. I'm going to look back from the 1950s to 1998 and then to today. And how has that changed? Has the physician-patient relationship changed? Has it changed as much as society and pop culture? We'll look at that. And then we'll go into healthcare today, physician-patient relationship, and how to preserve it, and then take that in to the next 15 years. We've been a society for 15 years, and we're going to look to the next 15 and what we can do. So first, ancient history. I think we all understand this. We're in our cancer center. We're the head and neck clinic. We have a multidisciplinary clinic. All these other people are outside. Are we living in a brigadoon, an idyllic place that is unique, rarely entered by outsiders? Very few people understand, and it never changes. And sometimes I feel that way. I'm sure some of you feel like that. Nobody understands what we do. We're taking great care of patients, and we don't need your input. Leave us alone. So sometimes that's true. But then I saw this, that this was all of our faculty are here. All of our nurses are here. All of our nurse practitioners are here. So who's back at our place? Is it going to be the robot that's going to be seeing our patients in about 15 years? And so you wonder, this technology is here. You could look on your iPhone right now, look out the robot camera, and examine your patient. So is this a sign of things to come? Are we removed from the forces of healthcare change? So the Patient Protection and Affordable Care Act, otherwise known as Obamacare, meaningful use criteria, all of you in the United States understand what that is, electronic medical records and health records, instrumentation, telemedicine, these are all beginning to impinge on our patient care relationship. You guys have all been called. I need a peer-to-peer review. What is that? Somebody says our test we ordered doesn't need to be done, and we have to get on an 800 number and talk to them and make that change so our patient can get care. Allied health providers, scribes, medical assistants, these are becoming commonplace in our practices. This is examples of what we see every day. You'll see a physician examining a patient and a scribe over here entering into an electronic medical record or a PDA, entering what's going on in that patient. And then we have to come back and edit and sign. And so these are all beginning to disrupt patient care. And what kind of effect is that having? So, as Heraclitus from Plato's Cratylus 2,300 years ago, change is the only constant. And is that true? This was the quote that came from the Cratylus. Everything changes and nothing remains still, and you cannot step twice into the same stream. Doug knows it's not true. My fly fishing in Colorado, I go back to the same stream every time, so I know where the trout are. But is this the only constant? The current reality is, you read articles, you can pull up online today, New York Times, USA Today. The only constant is change in healthcare. The Affordable Care Act, the only constant is change. Economists, philosophers, even physicians, broadcasters, that is changing healthcare. And how is that impacting the physician-patient relationship? So that's what I'm going to emphasize today. The ultimate constant is actually going to be the physician-patient relationship. So let's take a step back in time and have some fun and look at the world that we used to know. Dr. Ghislaine so eloquently yesterday discussed Hayes Martin and the history behind Hayes Martin, as well as John Connolly, developing these two parallel societies that merged in 1998. And what was happening back then? Physicians were talking to and caring for and comforting patients. And these guys are evidence of that. This is from an article from Dr. Connolly. The engagement requires asking questions, listening to answers and other revelations, communicating on several levels, examining and touching. The moral bond between the patient and the physician is that the physician will make a commitment to try to help that patient in his predicament. And that predicament, for our purposes, is cancer. So what was head and neck surgery like in the 1950s? Suspension laryngoscopy. You could now suspend the laryngoscope and look down into the larynx. Well, we didn't have microscopy or endoscopy. That was emerging at the time. Smoking was prevalent and accepted. The radical neck dissection was popularized by Hayes Martin and others, and selective neck dissections had yet to be described. Skull-based surgery, endoscopic surgery, microvascular, robotic, decades away. Hayes Martin in 1951, this highlights where we were at the time. There remains today considerable variance of opinion as to the practical value of and indications for such an operation, prophylactic neck dissection. The case for prophylactic neck dissection. So essentially doing a neck dissection for an N0 disease. So that's where we were in the 1950s, and he was way ahead of the curve. This is an article sponsored by Philip Morris for the Lucky Strike cigarettes. So we had cheerleaders talking about Lucky Strike cigarettes. This won an award. Philip Morris sponsored it, and it was very popular. And each of these figures here in this live video were talking about smoking and how it really helped these guys and gals in their day-to-day lives. And so that was very interesting. I'd hate to see one about HPV today, though. In 1954, the World Cup. The world listened by radio to the World Cup. The first televised World Cup was 1954, and not very many people had televisions at the time. This was in Switzerland when a country named West Germany beat Hungary. There also was a country in the World Cup in 54 called Saarland. The French might remember that, a French-occupied territory of Germany. They participated in the World Cup in that year. 60 years ago, Godzilla premiered in Japan. The Japanese know that, right? And so that was the first time it premiered. So let's fast forward now to 1998, the merger of the two societies. We're now an American Head and Neck Society for the first time ever. We're general surgeons, plastic surgeons, head and neck surgeons, maxillofacial surgeons, speech pathologists, nurses, researchers, and we're all together in one organization having joint meetings. Elton John re-released Candle in the Wind in honor of Princess Diana. And in the other football, there was the Mile High Miracle. A guy named John Elway led the Broncos to the Super Bowl title, while a guy named Peyton Manning played his first year for the Indianapolis Colts. And now that marijuana is legal in Colorado, we know why they said Mile High Miracle at the time. So 98, France won the World Cup, beating, sorry guys, a guy named Ronaldo from Brazil. A lot of Brazilians in the audience today. A guy named Michael Jordan led the Bulls to the title in the NBA. The Yankees, of all teams, won the World Series, and a guy named Bud Selig happened to be named commissioner of Major League Baseball. What he didn't realize is that his job wasn't quite so bad. He could have been commissioner of the NBA. So Monica became a household name in 1998, but a guy named Bill Clinton was co-man of the year. There was a company that started in 1998 named Google. I don't know if anybody's heard of that. And the first iMac was released in 1998. The iPhone, believe it or not, it was about a decade later. There was a guy named Michael Douglas who starred in A Perfect Murder and a small film about an iceberg in a boat that won Best Picture. Godzilla was re-released in 98 and again in 2014, so some things don't always change. Third time it was released this year. There was a show called Seinfeld where 76 million viewers watched the very last show in that series, and a new show called Sex and the City was released for the very first time in 1998. I never understood that too much, being from South Carolina, because we don't have a whole lot of sex or city. In 1998, my son was born, soon to be my daughter, and some things do and don't change. And this was last night at Central Park. And so another thing that hasn't changed is patients are still talking to and examining together with patient physicians in the room together, comforting through cancer treatment and cure and quality of life and survivorship. And so that's something that I don't think is going to change. So to know more about the physician-patient relationship, we've got to understand the true definition. And if you look back at all the articles on the physician-patient relationship over many years, most of them were legal in nature. It was a contract. When did that physician-patient relationship start and finish? And was the physician responsible for that patient at a given time? So the American Medical Association came up with a definition. A patient-physician relationship exists when a physician serves a patient's medical needs, generally by mutual consent between the physician and patient. A lot of legal cases have come up with when that starts and finishes, and you guys all understand that from the malpractice world. Really, the landmark article on the physician-patient relationship was by Emanuel and Manuel in 1992. Don't worry about all the busy nature of this slide, but I just wanted to show you there are 4 main categories of the physician-patient relationship, and this kind of exemplifies what each category. Are they a counselor? Are they a friend? Are they a guardian? And so each of us knows, depending on the patient, their domestic relationship, their knowledge, their education, we are treating that patient a little bit differently. And these are the general categories that these fall into. Pellegrino, CEO of the different guy. This guy was actually chairman of the Committee on Bioethics for President George W. Bush. And he has over 500 articles written on bioethics, philosophy, and the physician-patient relationship, really one of the leaders. The purpose of the physician-patient relationship as healing, curing when possible, caring always, relieving suffering, and cultivating health. And I think that defines our relationship as head and neck surgeons with patients. We're facing the Patient Protection and Affordable Care Act, patient rights, insurance restrictions, issues with VA health care. And as Dr. Medina, this is a quote from his presidential address in 2001, the problem's more evident than ever. Many government, insurance, regulatory agencies have renamed physicians as providers and patients as consumers. 2001, almost 15 years ago, and we're still facing the same issue. So I went to the Obamacare document, over 200,000 words, and how many times was the word patient, physician, and physician-patient relationship quoted in this? Patient, 718 entries. Consumer replaced patient 175 times. Physician was only used on 331 occasions in all this entire document. Insurance exceeded all of those terms, and the physician-patient, 0. Bob Byers, I was there. I was just finishing my fellowship. The obvious issue is over the right of a patient to choose his or her own physician. We're being monitored by numerous, even more than this now, different organizations and bureaucracies. And we're aware of those. And that's something we're going to have to fight to protect this relationship. A lot of papers have been written on ethics and law and the physician. It used to be the physician versus the patient. That physician was at fault because they didn't follow up on my test. And that patient was at fault because they didn't follow up. So most of the legal cases were back then. Now, the issue has evolved into the right of us, physician patients, versus the rights of insurance companies to decide what the two of us have decided. We want this patient to have surgery. The patient agrees to have surgery. Insurance company is saying no. They're saying you can't have this CAT scan, you can't have this PET scan. And we've decided that. So no longer, the physician and patient are now more a team than ever before. So this highlights what we're facing today. Are we now taking care of a computer when we're putting our stethoscope to the electronic medical record? This was a study looking at computers in the exam room, the differences in the physician-patient interaction, and the dark is when a resident actually went in first, and the white columns are when there was no resident in there. And because the resident was often documenting, the patients did not feel that they were getting that bond as much as when just the physician went in and was not documenting. This is a paper out of American Journal of Emergency Medicine from last year. The average emergency medicine faculty clicks 4,000 times. They are involved in data entry 43% of their day, patient contact 28% of their day. This is a study on internal medicine residents. They were at workstations 43% of their time, patient rooms 20% of their time. And what about medicine interns? Computer time occupied 40% of their day. Indirect patient care through consulting, talking on the phone, entering things in the computer was 64%. Actual one-to-one patient care was 12% of their day. So this is what we're faced again, the patient rights, the legal issues, malpractice issue, and Dr. Isley said, medicine should be practiced based on trust, which is fundamental to the physician-patient relationship. And as I looked back over all of the presidential addresses, and I actually read all of them, I got a lot of sleep during that too, but just kidding, just kidding, just kidding. Yeah, it'll be the same with this one, but they actually, I was specifically looking, none of them were titled physician-patient relationship or bond, but almost every one of them had a quote about that relationship. And so I was pleased to see that. So I'm highlighting some of those today. So the question is, are we more involved, more engaged in actually documenting what we're doing or doing what we're doing? Are we taking care of the patient, or are we more worried about making sure the documentation about us taking care of the patient is involved? So I think we're being pulled a different direction, and that one-to-one bond may not be there. And I looked at several legal studies. The malpractice environment is fueled less by quality failures or failure to do the right thing and make a mistake than by failure of our relationship with patients. And the communication has been highlighted as #1 reason that physicians get sued. Patients who like their doctors don't sue, no matter what the lawyer says. Poor communication increased the likelihood of malpractice lawsuits regardless of whether or not an error occurred. So I ask you, communicate with your patient, and one of the things you can do is if there is a mistake, if the patient has a complication, don't avoid that patient. Don't get them to see another doctor. Follow them up more frequently. Talk to them about it. Be honest, open, and truthful. This is what happened, and this is what we're going to do about it. And most of the studies show that's the best way to alleviate the malpractice considerations in that. So I ask our society and our profession to pave the higher road for the future generations of head and neck specialists. Maintain that special bond with our patients, or we will all be at risk of losing control over the decisions regarding their care. Their length of life and quality of life depend on this commitment. So now preserving it for the future. So #1, prioritize the physician-patient bond in patient care. We must continue to maintain that leadership role in the multidisciplinary clinic as well as head and neck oncology care. And we must integrate this relationship into future healthcare changes. So we must be at the table, we must have a voice. Dr. Shaw, young man here, 1991. We must train specialists who will not only treat the disease, but also the patient affected by the disease. And Dr. Levine, across all surgical disciplines, the head and neck surgeon has long been recognized as the most committed and dedicated to patient care. We must continue with an unwavering dedication to the improvement of the care of the head and neck cancer patient. It is our legacy. Dr. Bradford and Weber both focused on multidisciplinary care and quality of care using multidisciplinary care in their presidential addresses. So back to Pellegrino, and I think this is most important. The good physician will be the one who exhibits those character traits which most effectively achieve and indeed are indispensable for attainment of the ends of medicine. And he gave us 5 characteristics and these 5 traits we should follow. Fidelity to trust, benevolence, courage, compassion, and truthfulness. And so I've modified some of his statements and customized them to head and neck cancer. Fidelity to trust. Because the cancer may be unyielding and treatments, cancer, and side effects may be unavoidable and unpredictable. So the patient must entrust the physician to proceed with caution. Benevolence. Because first doing no harm can sometimes involve doing what is most complex and risky. And first doing no harm can sometimes involve doing nothing. Maintaining benevolence does not always involve being conservative. Courage. The physician may have to risk complications, accept failure to cure, and compromise time for oneself and their family to care for patients with head and neck cancer. We may have to battle insurance companies, hospital policies and administrators, and a system of traditions to provide the right care for each individual patient. Compassion, because cancer is life or death, and sometimes death is the preferred path for patients who value quality over quantity of life. The physician must understand each patient's desires. Finally, truthfulness. Because some head and neck cancers have a high mortality rate, the physician must honestly educate the patient on the realistic expectations, risks, prognosis, and quality of life. And I want to conclude that with virtue and phronesis. Virtue, the foundation of our profession, and the primary virtue is phronesis. The moral and intellectual virtue that disposes a physician habitually to choose the right thing to do in a concrete moral situation. And to our future. Healthcare is changing and technology is changing. From Dr. Johnson's address in 2005, we as head and neck surgeons stand at the edge of a precipice that threatens to change the way head and neck surgery is practiced around the world. 10 years ago. It's true. So the ultimate constant, I believe in 15 years, many aspects of our patient care will be changed, but the connection we have as head and neck surgeons with our patients will remain constant. I believe each head and neck cancer patient will be seeking an individual physician, not a hospital, a health system, an electronic medical record, a robot, or an insurance company. And the physician-patient relationship will remain constant. Where will we be in 2028? This will depend on each and every one of you. It'll depend on our physician-patient bond and the efforts of our emerging leaders. I'm honored to serve this society and our patients now and in the future. Thank you. Thank you. That's okay. That's okay. All right. Thank you so much for this opportunity, and definitely unnecessary, but thanks for attending. So we will move on to presidential citations. Can we have the next set of slides? So as president, we have the opportunity to give some presidential citations. And as I thought about these, I thought about who had affected me in my life, not just career-wise, not just professionally, but also personally. And so I've come up with a lot of these people. You may have heard of some of their names, you may not have heard of some of the others, but they've made a direct impact on what you do, I promise, and what I do for sure, directly and indirectly. They've all been involved in head and neck cancer care worldwide, even though some of them work in a microcosm, maybe in my offices and around there. So first, Anand Sharma, and Anand could not be here He's our radiation oncologist. Also a head and neck surgeon, trained in India, moved to New York, revisited otolaryngology after radiation after otolaryngology, and now is our head and neck radiation oncologist. And of course, he's traveling to India right now to visit family, but a colleague, advisor, friend, and an artist. Doug Gerard, what can I say? He's already said it. A great guy. We've been friends for many, many years. Consider him a great friend in my career as well as my personal life. And I've just highlighted a little tidbit of information about each of these people that you may not know. He's a race car driver, and he's had a few crashes. Don't tell me about judgment. Boyd Gillespie, colleague, advisor, personal friend, and a historian. If I ever want to know who was involved in what war, in what town in the North or the South, or anywhere else in the world, I go to Boyd. He's read every book, and a fabulous guy. Thanks, Boyd. And I guess yeah, you want to bring those up? We have to get a picture with Doug first. Are we okay to do this right here? And Boyd. Sherry and Nathan. Sherry Ann I met when I was at LSU. She was in San Diego. We started talking research. We started talking collaboration and became great friends and have been on ski trips and other events together and gotten to know each other's families. So such an honor to be a friend of Sherry Ann. As you know, she and her children are incredible musicians and performed on NPR as well as others. So Sherry Ann. Julie Blair. Julie Blair is, I don't know how to say it. Every laryngectomy patient in the Southeast has her cell phone number. They text her if they have any problem with her prosthesis. And I found out she put in the electrical wiring for her entire house. And I didn't know that. So she sings in the church choir. Julie is incredible. She's a patient advocate. Has been our speech pathologist ever since I've been there and is an expert in the field. Julie? Josh Hornig. Josh, for those that know Josh, Josh is a very unique individual. He is a master of just about everything in the world, and incredibly skilled surgeon, really one of the best technical surgeons I've ever seen, a friend, snowboarder, won barbecue championships, musician. I could go on and on. Josh? Judy Skoner, same thing, technically unbelievable surgeon. I don't remember any flap that's ever failed. She's been there I don't know how many years. Just amazing attention to detail, meticulous, and above all, she has such a commitment to her family and her patients, and a very faithful friend. Judy. Del Yarbrough. Everybody knows Dell. The guy is brilliant. He is amazing. His brain works in every direction all the time. And despite his accent, he really knows what he's saying. So don't let that fool you. Dell? Ashley's known. She is our head and neck tumor center nurse coordinator. Has been there for many years. She does it all. She does our research, our clinical care, organization, administration. She personally is a committed supporter for family, friends. Anybody that ever gets sick or has a problem, they go to Ashley. Little do they know that she's also taking care of somebody at home and other people. And I didn't know she was a floral designer, but I found that out recently. Betsy Davis. Betsy is our maxillofacial prosthodontist. She makes our patients' eyes, ears, noses, palates, teeth, whatever it takes. And she is the ultimate perfectionist. She does not stop until you can't tell that they ever had surgery. She's a great friend and golfer and artist as well. Betsy? Finally, Ann Durgan. She runs my life. She is a mom, a wife, everything. She's been my administrative assistant forever. The greatest thing is she loves the sun, she loves the tobacco, and she loves the wine. And she actually put it in her bio, but they forced her to take that out. So there is nothing Ann can't do. And if they let her in, I think she could probably do surgery by now. Ann? Okay. Finally, awards and guest of honor. First, Jesus Medina. Dr. Medina was a junior faculty at Oklahoma when I was a medical student, and he doesn't remember the early days when I was watching him do a parotidectomy, and I was already applying to general surgery and just couldn't wait to match in general surgery. And he said, "You ought to think about this otolaryngology," and it was already too late to apply, and somehow things fell into place. But role model, fellow Oklahoma Sooner, and for his leadership and commitment to this society for many, many years, Dr. Medina. And finally, not the first facial plastic surgeon to receive this award. Dr. Stucker took a chance on a young medical student like me who definitely had not achieved as much as I could at the time, and gave me a chance in residency and has given me much advice and support. And probably a chairman, despite all the other things he's done, I have never seen a chairman more committed to the success of his residents and students and there for them. So thanks for being you, Dr. Stucker, and for your support for my career. Okay, thank you very much, and that concludes. Thank you for such a great year. I appreciate your commitment to me as president. Thanks.